specialist?
You can see the rise in our importance by the size of the room. Obviously, because we're getting near to the end and hopefully get towards some conclusions. So, first of all, can I thank Sean and James for coming on? Really appreciate it, because we're going to be the last ones. We have had, I think, is this the sixth?
Fifth, isn't it? Yeah.
And I think we've been told what we're trying to do is obviously produce some conclusions, which in November, which is the 25th.
That's right. Yeah.
We'll be presenting to Secretary of State as to what we suggestions, if you like, as to somehow some kind of improvement both in diagnosis and outcomes in terms of this dreadful disease. So we're really grateful, and as I said jokingly at the beginning, Sean, I'm told you to have all the answers, so we've left you two till last. It's quite informal. Myself and here officially the parliamentarians, so we'll give you some time to say your piece. We'll ask a few questions. We have around us a very informed and very audience of skilled people, and I'm a very, very kind chairman, and right at the end they're dying to say something. I allow them to do that, so that's how it tends to work. It's recorded and everything else. And I always say to witnesses who come, if when they leave this august building, it suddenly strikes you that you should have said something, or something comes to mind, then please feel free to just email it in, and we'll encompass that as well. We're just trying to get, as I said, some degree of improvement in the system. So, shall I go with Sean first?
Okay.
Alphabetically.
Thank you. So my role in this is National Clinical Director for Cancer for NHS England. So it is a NHS England appointment as opposed to a Department of Health appointment. So there's a difference as a result of the new system. With that means that I function within the Medical Directorate of NHS England, and therefore what's at my disposal in terms of function is what's available through the Medical Directorate and what's euphemistically known as matrix working, so that we have to fit in with the new structures that are, I have to fit in with the new structures that are in place. For cancer, I've been grateful for the last 15 years of policy development, so there is very good legacy handover from Sir Mike Richards into the role, and equally a large amount of things on the to-do list. And I guess my immediate job in coming into post middle of April of this year was to try and ensure that we capture the elements of the work to see where it can be parked within the new system and then kept alive. And secondly, the field force that would be required to help me in the job. So that my priority from day one was to ensure that the strategic clinical networks that were kind of resurrected towards the end of the changes of the NHS as a result of the Health and Social Care Act did not go into abeyance, and were there for my connection to what's happening at the coalface and at the ground. So what I've got in my second quarter, if you like, of time in this post is then clarifying the work programmes that are required to do, and to ensure that they are fitting with the NHS England programmes of work that are driven by the domain directors, the new directors in NHS Medical Directorate, and also fit with the needs of the cancer community at large. And it's of no surprise that issues like early diagnosis and awareness raising are top of that agenda, as is survivorship and quality in terms of information and informatics. So that now I'm at the phase where I'm pulling in people to help me with each of those tasks and work programmes. So I think. And in relation to this, I've already given a presentation at the Pancreatic Cancer UK annual meeting, which was a few weeks ago.
Why?
So they caught me early.
Right.
In it. So that's me.
Okay. James, do you want to?
Yeah, so I'm National Clinical Director for Specialised Services, so no particular type of those specialised services. My role has been, over the last 3 years actually, been working for the future NHS England through NHS Commissioning Board transition, was to bring to specialised commissioning, which is the element that NHS England has to commission directly, and not through CCGs, a structure of clinical leadership. So there was a desire that CCGs would be clinically led. So it's been my job to bring in clinical leadership into the commissioning of the specialised services. Specialised services accounts for about 12% of the NHS spend. We cover 200 service lines. We have constructed our clinical leadership through what we call clinical reference groups, and we have 75 of those, each with 14 clinicians from geographical different parts of the country, and 4 patient and public voice representatives, which have been selected through a national recruitment process, a lead commissioner, public health support where needed, pharmacy support where needed, and we try to develop the commissioning of services through that clinical leadership structure. We chunk it up into what we call 5 programmes of care, and Sean is actually our clinical chair for one of our programmes of care, which we call Cancer and Blood. It's my role to put in place the way that we commission services. We think we've defined some innovative ways, and the key ones I think you want to hear about a bit later are how we develop service specifications, why they're important now, and how your process might influence what those future specifications might look like. And I'd be pleased to talk about that further when you want to get to that bit.
Yeah, I mean, one of the things that's come through very clearly, I think, in the evidence is this whole issue around early diagnosis and also the difficulty of achieving that with pancreatic cancer because of the non-specificity of the things that come forward. Are there any ways of driving that forward that either of you can say?
It fits more comfortably, I think, with me in terms of early diagnosis tends to be in primary care, and that is CCG are responsible for their practices within it, but they're equally responsible for commissioning diagnostic tests. When you listen to patients, the key thing recurring theme that I receive anyway is yes, there is lack of specificity, but it also seems an inexorably long pathway that you have to go to in a temporal way, that one test will lead to a set of usings and thinking, and then maybe another test, and it seems to be just taking too long. So that's a system that, you know, it becomes thrown into relief in a disease like pancreatic cancer where there's non-specificity, but actually you would get the same potentially discussion about other cancers. So the road that was set about originally for cancer was to say, well, when you get diagnosed, the system isn't right. So that's the first thing we need to put right, and that was the first 10 years, if you like, of the cancer strategy. And now we're just 2 or 3 years into early diagnosis, where there was precious little knowledge about what you can do in order to change the system, what you need to do. And from my perspective, there is it doesn't make sense that you get access to tests when you're in secondary care in an admitted way as a patient. That's a lot quicker than when you attend your GP surgery. So what have we learned from the early awareness and diagnosis campaigns so far, which have been really quite important, because, as I said at the start, there was no real evidence available to say what's best to do, but there was a lot of cynicism in that if you create awareness about symptomatology in general, you're just going to flood the system. Actually, now we've got 2 or 3 years' worth of evidence from the Be Clear and Cancer campaigns, which have shown that no, you don't. It's all manageable, although I would acknowledge that we've concentrated on the bigger volume cancers in terms of the commonest cancers initially, but the lessons are there to be learnt. So what can you achieve? You can achieve awareness of symptoms that will drive you into action. Can you change GP behaviour? Yes, you can. Using those campaigns, you have an increase in referral and you have an increase in diagnostic testing. And do you change the ultimate impact in terms of whether that leads to either earlier stage disease or more operability, therefore curative intent. Well, in some cancers we're seeing the evidence that that is the case, but it has taken us 3 years. We know that in the audit of pathways of care from patients into the diagnosis through GPs, that there is a lot of activity in the first 2 weeks of attendance for symptoms, but then a long tail. And that long tail is either lack of access to diagnostic testing or a delay in between going back, and therefore a lack of safety netting within primary care. And I know that that is not universal. So I think there is a lot that we need to do in the development of that relationship between public patients and primary care and access to diagnostic tests. It is the biggest thing. I got challenged in this afternoon. We had a good debate at our latest launch of Be Clear Cancer, which is Blood and P, which is about kidney cancer and bladder. And to me, I was asked, well, what do you want of GPs? Now, I want a GP to listen to his patient, take that history and do that examination and order the test that GP needs based on clinical judgment and get it in a timely way.
So, there was some debate early on in our evidence about GPs being able to refer direct for CTC scan.
Yes.
Is that something you would have sympathy with?
We had I have absolute sympathy with, and we had an example today of a GP in London who said he can get access to CT, and around the country you can, but it's terribly variable, and that's just not satisfactory. And I think that we, in our early days in early diagnosis work, we pushed hard on what's the best first test so that you could give advice. If you raise awareness, then for the general practitioner or the practice to say, well, what's the one that's going to lead us to the earliest signposting for diagnosis? And I think we've moved on from that in that you would like to think that in whatever given set of symptoms, you won't rely on just one test to give you the answer. You need to be able and be prepared to say, well, this is what I'm doing now, and if that doesn't show up anything, I'm going to do this test. And so I don't see a difference. I mean, I think diagnostic testing has moved on so much. CT now, virtually any patient with a possible acute appendicitis nearly gets a CT when they're admitted to hospital. So it is becoming much more used, and therefore, why is it the purveyance of secondary care to judge why you might need it? There is going to be a debate on this in relation to how that might be achieved. But the other things that we have seen through the awareness campaigns and through the introduction prior of sort of cancer waiting times, for example, is that these things are achievable. You might have a hump to get over in order to get more readily accessible access, but you do achieve it. So that when the 2-week wait cancer first came in, everybody thought that was going to be undoable. It was the first one that was cracked, and it delivered on it, and it's been consistent ever since. So that means you dealt with a backlog, and then your practice and custom was to order or to use it. And then if you think of the example of breast cancer, where it was 2-week wait for just symptoms that you thought were related to breast cancer, then very quickly within the decision to say, well, we go for all breast symptoms are eligible for a 2-week pathway, that created no noise and was delivered within 6 months. So I would say the time is right to kind of bang the drum to say we need to maybe look at what are the needs of the clinicians who are trying to make a decision around the patients that are in front of them.
The other thing that's come through quite strongly to me in the evidence we've heard is whether there is benefit from having a pathway for non-specific sort of cancers, as it were. There are clear pathways for other things, but whether there's some gain to have that pathway clearly delineated.
Yeah, and I think I think that becomes slightly difficult when you're trying to work out how to physically do that and achieve it. And I would have thought that sort of the analogy with the cancer of unknown primary when a patient presents with disseminated carcinomatosis and you're trying to find out what it is, it creates a real difficulty and it deflects you away from what your message. You're putting something in a little silo that you say, okay, well, if you've got vague symptoms, these are the different type of tests. I'd like to push it back into the clinical community, which should be up for it to say if we've got good safety netting and we're listening to patients and we're not letting them drift in between consultations, what are the tests that you need? And if there is an educational requirement where both primary and secondary care start to talk to each other again about honing up on the diagnostic skills and the use of the test, the appropriate use of tests, so be it. I think let's be up for it. Would be my view.
In a sense, can I take it on from that? There was quite interesting, I thought, comment. And somebody talked about specialist doctors, and one of the issues here with non-specific symptoms is being sent over a back problem, and the back specialist says, no, it's not. And then back to the GP, who then decides it might be a stomach, so you go to a stomach specialist. And what I was trying to say, that the back specialist might be a back specialist, but he's still a doctor. Can't he then say, well, actually it's not, but you're here, let's try. Is that impossible in the system?
I think there's variable. What I hear is two sides to that, as in within primary care there is, I like to know my patient and therefore I would like to be responsible for what their next steps are going to be. And you equally hear the opposite view within secondary care where my job is to do this element of I've been asked to make or establish a diagnosis or not. And the next path is really probably more appropriate in another specialty. In my own practice, that's what I prefer. There is an issue within the system of managing demand, which I meet on a day-to-day basis, where because of the pressures within secondary care, internal referrals are often seen as a way of continuing aggregating resources within secondary care on a too much of a basis, and therefore sucking up resources by referral. Yeah. It's a knotty one. I think that it shouldn't be that there is blocks, but there are in reality.
But if you got into a system where GPs, or primary care, whatever one wants to call it, had the ability to diagnose and was sending somebody there, but felt there was something serious, but the patient was complaining of back or stomach, shouldn't that therefore send a trigger that actually the GP is not just sending somebody on and needs to go back, that actually there is, I don't know, some kind of classification that although I am sending you patient A, which I think is a back problem, but they think it's a bit more serious than that. Well, I suppose they think it's serious to send it to a specialist anyway. You're already making a decision, aren't you?
You are. I mean, I suppose if you take something like back pain, which would be either an orthopedic surgeon or then I think each specialty, as you send it in for it, becomes specialised. And therefore their ability to look beyond that, whereas the GP is very much non-specialised and is more...
But I think the argument would be important that once upon a time the specialist was a doctor, presumably still is, and had a general responsibility as well as their specialist.
But the training programmes are designed to create specialty.
I think medicine's moved too far on now. I think it's very rare to find a generalist doctor within the specialisms. So it's very hard to find a general surgeon or a general physician. They will be specialists in their diabetes. So I think we do need to promote that the primary care doctor has got to take on the role of the generalist. And I don't think there is now that place within hospital medicine to be sent into a generalist in that same way. I think the system's changed too much.
But therefore that should add to the argument to give more grit to the GP in terms of diagnosis.
Yes.
Yes, it does.
It does.
That's the critical
Yep.
area in terms of that.
Yes.
And specifically in terms of, one of the other issues being raised is concern, is two-sided, the clinical nurse specialist in how important that is in this whole scenario of evidence and evidence and evidence. At the same time, there's been also the dangers with everybody in budgets and so on, somehow that position is a vulnerable one. I don't know if you've got a view on that or...
Well, there's no doubt that clinical nurse specialists make an impact. Each successive cancer patient experience survey has demonstrated that amply. The assurance for cancer comes through the peer review process, which is still continuing, where each organisation has to show evidence. And you know, I was a network director and medical director for 8 years, and that was the constant discussion through peer review process in terms of pressurising the organisations to deliver on it. What James has described as the way forward in specialised services, but I would say you should have the same for all cancer, is creating the specifications that then get built into binding contracts, which is a new world we're into, because I was part of the development of the cancer specifications, and I do sign up to them being a really, really important element for that. And all of the cancer specifications, because I've created most of them anyway, are based on improving outcomes guidance, the IOG compliance, and therefore the requirement to be peer review compliant on the back of the measures which assess that. And we're both supportive of the concept of assurance and peer review going forward. I think it's quite part of what NHS England should have.
So, would you support that?
Yeah, absolutely. Yeah. The peer review process, I think, will be the process that will maintain that assurance that the nurse specialists are there. We will need to demonstrate the benefit that they're having for the pathway, but I don't think it's that difficult in these particular cancers.
Right. And another issue that's come up is data on pancreatic cancer and the difficulty of getting data out of the system. I mean, have you got views in terms of that?
I don't know where do you want to go with cancer?
In terms of getting data, where is the difficulty in terms of getting the data? Because the data on incidence, prevalence, survival is there. It's part and parcel of cancer registration. There are 3 data sets that are on stream which will be very relevant to data going forward, and I think the automating the data collection is quite important in this. But for cancer services, you will already have HES data on episodes, so for operations you'll be able to...
Specific to pancreatic, or will it be?
Yeah, it's coded to the procedure that's carried out.
Right.
For chemotherapy, the systemic anti-cancer therapy SACT data set is on stream, is gathering data already, so you know what treatment people are getting. For radiotherapy, equally, there's a radiotherapy data set. All of those allow you to have little 3 sets of circles that will join up, that will give you, ultimately, you will be able to link those to survival and registrations. So you'll be able to see what decision an MDT made, what treatment the patient actually received, and how well they're doing in terms of survival. And you marry that with patient experience, where you're on surveys like the National Patient Experience Survey, then you've got a richer set of information. Where you may get difficulty, where there is difficulty, and I acknowledge that, is being able to extract from, for example, the patient experience survey, easy, reportable, tumour-specific information. But it's there, because I know in every single organisation, 162 trusts in the country, there is data from patient experience, and it goes down to an MDT level. That's the richness of that data set. So it's got to be there.
Eric, also, if I could clarify, I think one of the issues that's come up is about the ability to extract data about pancreatic cancer waiting time, referral waiting time targets. So it's bundled into an upper
Yep.
GI category, and I think one of the things that we felt quite strongly about is that if the data is there, it just feels quite frustrating not to be able to extract it to really evidence whether pancreatic cancer patients are experiencing longer delays than perhaps other cancer patients in terms of that, the first wait for referrals and for treatment. And also, as we had been chatting about earlier, we have had a commitment about the government publishing pancreatic cancer responses within the National Cancer Patient Experience Survey as a kind of separate data set, acknowledging really the fact that those patients have much poorer experiences than other patients. So we were just chatting about it earlier in that.
That was news to me.
Yes, indeed. So I think it's about kind of Department of Health possibly in the transition.
You mean somebody's not talking to somebody? Very unusual.
Perish the thought.
Go figure. But I think that was our conclusion. So, but we will follow up on that. But I think it is given where pancreatic cancer is in relation to other cancers, that where we do have data that can shed light on experience and really, the quickness of diagnosis and treatment, or the slowness, then it feels important that we use that, and that doesn't feel like a big ask, I suppose.
All right, well, let's see what we can find out. Can I ask you generally, both of you, where do you see, obviously we're concerned with pancreatic cancer. Most people have got involved in this because of personal circumstances and a feeling that somehow things could have been better. Is that your view, or does it sit with a group of other cancers that, specialism, you feel that the situation's improving, or that...
Well, over the last 30 years, the one-year survival is improving.
Yeah.
And the 5-year survival is, at the moment, is at 3.6% versus a 5% European average. So things are slowly improving. What strikes me is the patient stories. One of your witnesses emailed me in anticipation of this meeting, and you read that and his wife's blog, and you think, yeah, actually, I can see this. So I think there is a problem. There are delays. It's a bit like sort of walking, then trotting, then cantering. It just seems to take forever for it to happen, and then it's all panic at the end.
Yeah.
So it feels like it needs to come back, and I think the crucial of this is access to diagnostics.
And where would you put pancreatic on the list of cancer then, do you think? In that sense, do you think it is?
It's difficult cancer.
It's the most difficult, or what do you put it in that category? And you, James?
Well, we've tried hard in what we've been doing to give equitable access to commissioning.
Yeah.
So we really want to be able to give the same amount of effort in every bit of the services. So the design is, so you're not having to focus on 5 areas this year.
Yeah.
We actually want to focus on every area and improve every area. So in terms of importance in focus, I think it's equally important as everything else, but I think the focus that you're giving it in terms of what can we do next to focus is really quite appropriate, because it is I'm speaking as a clinician, we know it's a difficult cancer, and rather than as a commissioner.
So what steps need to be taken, A, to move the UK up to the European average? How do we do that? And secondly, are there steps that can be taken globally? Because actually, globally, it's pretty woeful, isn't it? Are there things that the global health community perhaps ought to be doing?
Well, in terms of the global, I think that it's a really hard area to conduct clinical studies in, and therefore, does the traditional approach to clinical trials resonate with this as a condition, which then is at the moment is diagnosed so late? So is that the way to conduct the evolution of innovation in treatments? At the Pancreatic Cancer UK meeting, I was impressed by the surgeons and the clinicians there in terms of the way they're starting to think, and they're adapting from what was traditionally a very surgical orientation to management to a more let's look at other innovations out there. So can you deliver different types of chemotherapy directly beforehand in order to make the tumour more operable and so on. And that really was, and that was generating a debate in a very traditional area, even amongst the enthusiasts. So that was really, really good. And you replicate that across the world, I think you've got it. I think the impact of the improving outcomes guidance, which is unfinished business in my view in parts of the country still, we've got work to do, but the number of centres that you reduce and therefore you put a critical mass of patient care within it is very important, and that networking then can happen globally because of the focus in those centres, because it isn't, you know, this requires that critical mass of all the clinical and the teams that are needed. So that's the global one. I think the steps, local or nationally, here is really about learning. I think what we've learned through the awareness campaigns, the ability to change behaviour within general practice, the benchmarking of the quality approach to driving up the standards within general practice. It is hard work, that, but I think it's worth doing. And you know, there may be 400-600 GP practices in the country. I don't know how many exactly there are, but you bet your bottom dollar there'll be a number of those will be single or paired practices in hard to reach communities with lots of difficult things to be dealing with. So this is not a short fix. I think we've learned the direction of travel, both from the cancer waiting times initiatives and the declaring cancer campaigns, that it can be done in changing behaviour, but you will unearth the blocks, and one of the biggest ones will be access to diagnostics, I think. So scoping that out in terms of what will be the need in this particular area. So if you break it down actually, in terms of look at the numbers, how many CT scans across the country do you really need? And it may not be a big figure. You don't know until you start to scope out that work. It will be, it'll have to be done, I suspect, in a sort of in a regional pilot way, where you look at that funnel of a lot of patients with a lot of vague symptoms, and then how you sort of get into the funnel to get at the end of the day. But that's where we've got to go to, I think.
So who's doing that work? That's
one of my main work streams, is the development of primary care, not specifically in relation to pancreatic cancer, but in relation to exactly that, in terms of unpicking and putting into place what we've learned from our evidence, if you like, gathering through the campaign so far into commissioning. That's what I think my role is, to try and bridge that cancer community into the world of commissioning in NHS England. I think in relation to pancreatic cancer specifically, there isn't a project set up to do that at this moment. We did try to attempt an approach with a campaign called Know for Sure, which is know for, as in for sure, trying to bridge this concept of a compilation of symptoms that might point you in the direction of possible something related to cancer diagnosis or risk of cancer diagnosis. But our experience in the local and regional pilots with that was that the messaging is incredibly difficult. There's confusion, and when you try and go to the public and say, you know, if you have any of these, go to your doctor. So I absolutely recognise the messaging difficulty that will come for this, which is why I think, if that is the case, let the symptoms be the symptoms, and let the clinician try to drive what they need in terms of establishing a diagnosis. It seemed a more feasible mechanism.
Well, then, can I take on to the research angle then? Do you feel enough has been put into research in terms of this particular cancer? I mean, clearly the answer is no, it isn't, but I mean, in relative, to other cancers and so on.
have you sought and views from NCRI as part of this? So that they're much better placed, because when I raise this with them, and this is pancreatic cancer is not unique in this, childhood cancer is exactly the same. They feel they're not getting the same support as they should. There is a genuine desire within the clinical community to design clinical trials to answer questions.
Right.
You come across the difficulty of implementation and creation of those trials and funding of them. There's no doubt about that.
Yeah. What we're saying is it's not a sexy cancer, so there isn't the money going into the research. Put it bluntly.
I don't think that it's not. I think in the clinical community there is a recognition that this is a pretty serious cancer, that there isn't many answers to, and I think if that is a sort of a good go at the pharmaceutical industry, because the numbers won't do it. I'm not sure that is. I just think perhaps that they are governed by a very strict GCP practice for the design of clinical trials, where you have to have clear indicators for trial entry for randomized controlled trials. I think what the view I was given, and that's their stock in trade. That's the only way they can do it, because if they don't do that, they don't get a drug that will ever get close to being licensed. What I'm saying is that I think that approach to research in this particular area at this particular time may not be the right way of conducting it. We have got, with the linked data sets that I've described, the potential for a new era for looking at intervention and outcome across a whole population which was never there before. So if every single hospital delivers in their data on the decision that they made on either treatment, be it chemotherapy or surgery, and that's automated and you collect it nationally, then you can see very quickly what happens within 6 months in terms of survival. So we are at the cusp of having a different conversation, I think, about interventions, and the blur between that as research development and actually real-time live commissioning is quite interesting. But it's a bit like the nirvana. That's where we want to go. But all the elements are there to do it. But it requires a different conversation, I think.
Anybody else want to? Sorry, go on.
All the sort of reference so far to the data collection has been in terms of treatment and outcomes resulting from treatment. Is there any data collection on actually who is treated, and those that aren't, what happens to those and the reasons for that decision not to be treated? Or does the data collection stop with those that are treated?
The COSD data set, which is the Cancer Outcome Service data set, is requiring each MDT to enter in what happened to any patient that is discussed. Yeah. So it will be palliative intent. It will be first-line chemotherapy. It will be surgery followed by neoadjuvant. That's the holy grail that we have for this data set.
Right.
And if there was a recommendation to push particularly for pancreatic and any other rare cancer by that, it is to push that what is being asked for by the clinical community gets locked into the contracting. So it's part of the specification, as you would expect. You'd like to see that any provider would get themselves involved in supporting research, in undertaking clinical audit, looking at their patient experience. These are givens that should be there, and that as a message would be quite strong.
But that doesn't exist at the moment, that specification.
It is COSD is mandated as was staging data since 2008 in the NHS, that should be provided electronically to cancer registries. The fact that we have a new system of cancer registration to combat that means that for the last 5 years that didn't happen. So as a constant message, it's a good thing to do, but it is there.
Sorry, gentleman there now.
Sure, can I ask you a little bit about this idea of changing the role of the GP? Because the system you described would convert a GP practice, which is essentially a triaging exercise at the moment, referencing out suspicious patients that require referral to secondary care, and making sure, so there's an oversight role, of making sure that the secondary care specialists are doing what they're supposed to be doing to the GP's patient in terms of achieving diagnosis and treatment. So you'd be shifting that role of making the diagnosis to the GP. That's a big shift in responsibility because you empower them with the diagnostic tools. And that would, to my mind, change what the GP is from somebody who makes sure that the specialist is doing what the specialist should be doing to actually becoming, in effect, what we talked about, or we talked about earlier, an internist. Europeans and Americans have these internists, often which are located within a secondary, within a hospital setting. So you're changing the focus and the nature of general practice completely by this proposal, asking them to try and look for relatively rare diagnoses and commit to a diagnosis.
No, I'm asking the GP to make a clinical decision on set a patient in front of them with a set of symptoms and to organise a test.
I think it's really important what's being proposed. I think it's really important that we get patients into the right pathway by making the right diagnosis so they get to the right pathway quickly, and putting specialisms in the way of a diagnostic test is not what we need in terms of both for the patient's experience of the pathway, but also of the value for money for the pathway, because it's very, it changes the
What I was thinking about really is that you're going to have a lot of patients with vague symptoms. A lot of patients. And very few of them, in reality, in a GP's practice, are going to have either pancreatic cancer, or let's say renal cancer, or let's say esophageal cancer. The numbers will be small. So the probability is that the majority of your investigations that the GP is enacting are going to be negative in their result. Or it's possible that the timeline that you've picked up a real problem is such that the investigation at that point in time is negative. So how do you cope with that?
Yeah, be up for it for a start. Be up for it for a start, I would say, because this is it is a different debate. I do exactly the same when I chair the ovarian cancer guidance for NICE, and the stakeholder comments back from primary care were interesting to say the least, and the volume was quite there. But and what we're proposing was saying it's okay for you as a GP to order a CA125, which was a simple blood test on the back of 4 very vague symptoms, in order to try and signpost patients away from 30% going to A&E, 30% going to gastroenterologists, and only 30% going to gynecologists for the investigation of these women with potential ovarian cancer. And do that first, and then do an ultrasound scan if that's raised, and you will shift that pathway, and it's economic. So but I'm well used to that as let's have this discussion, because I had it already today and we practiced it out. So I had 2 sets of GPs. I lobbed a little grenade into the room and off they went. One was very much saying, well, how can we do this? And he'll say, well, actually, I'm doing it. If I need a CT scan, I can get access to that, and it helps me. So and I'm okay with that. And I just think we're all kind of in this together, and we're recognising in my mind that if you look at the put it another way, these patients get diagnosed one way or another, so they get their tests. And when you look at the primary care audit that was done about 3 years ago in terms of what activity led up to that test, the vast majority of patients were seeing it was a skewed Gaussian distribution with a lot of activity in 2 weeks and then a long tail. And that meant that patients, when interacting with their GPs, for a lot of cases for cancer, they were on the ball together and it was moving and it was relatively swift. And all we're wanting to do is say, let's get rid of this tail, and what would it take to get rid of that tail? Because the patients ultimately do get a diagnosis, it just takes a long time. Now, it may be that my concept of earlier access to diagnosis is the wrong one, but I think it's a good starting point. And I honestly, once you get into the debate, there is clearly an appetite for this when you go around the country, because when we've tested that concept, say we want more proaction, so the awareness campaigns have led to a different set of behaviour. So you can't, and it hasn't met with resistance at all, and quite, to my mind, in fact, the opposite. The support from when you do the feedback and gathering the evidence, which we're doing in evaluation for the campaigns, both from primary care and secondary care, is universally positive as opposed to negative, whereas their reaction prior to this was very different. It was very sceptical, and rightly so. So of the 3 years that I've been involved in the campaigns, I've gone from having a roasting standing up there as being a heretic to say, where's the evidence for doing these campaigns? Show us that you're going to improve things. To today's example, which was really great, which was a different set of debate altogether. It wasn't questioning the reason for doing it because we were accruing the evidence that it makes a difference. It was more moving on to the next stage of the debate, which is here and now. But it's a good place to be.